Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. We will resume our conference. This session, we have three speakers. I'm chairing this session with Dr. Walid Hashim. Dr. Walid Hashim is a consultant, endocrinologist, and metabolic bone disease specialist, King Saud Medical City. Our first speaker is Prof. Eugene Mccloskey, who was introduced already. He's a professor in adult bone disease in the academic unit of bone metabolism of musculoskeletal research at the University of Sheffield. This time he's going to talk about fracture risk stratifications.
My name is Eugene Mccloskey, and I'm here to give a second presentation as part of the Saudi Osteoporosis Society meeting. And over the next 20-25 minutes, I want to talk about fracture risk stratification. These are my disclosures. So, fracture risk stratification is something that is a relatively recent phenomenon in clinical practice. We've had a number of approaches to intervention thresholds over the last 30 years or so. And fracture risk stratification really arises from intervention thresholds because they allow us to decide should we intervene, and increasingly recently about how we should intervene. So intervention thresholds have been around as long as we've had guidelines. And one of the first to be established was prior fracture. Osteoporosis is associated with an increased risk of fracture. And once you've had a fracture, then it would seem reasonable that that individual should receive treatment. And we're just applying the same logic there as is applied in patients having myocardial infarctions or strokes or other incident events in chronic disease management. With the advent of the T-score in 1994, there was then the opportunity to devise new thresholds based around the bone mineral density T-score. And we'll talk a little bit about those as we go through, and we'll also talk about some of the limitations of that approach in another talk. More recently, and by that I mean over the last 10 to 15 years, with the availability of tools such as FRAX, then there has been the ability to define intervention thresholds on the basis of absolute fracture risk. And by and general, two approaches have been used in that setting. First of all, an age-independent or a fixed threshold. And for example, the thresholds in the United States, where it's set at a 20% major osteoporotic fracture probability across all the ages, or a hip fracture probability of 3% across all the ages. That would be an example of that. Or they can be age-dependent approaches. And as I've said, and later in the talk, we will talk about further stratification, moving away from just an intervention threshold, a single intervention threshold, to different thresholds that actually advise us on which treatments to choose. So the next slide, we're just going to talk about the use of fixed thresholds. And for all of these approaches, both fixed thresholds and age-dependent thresholds, there are often sort of philosophical arguments about does this enable treatment in this subgroup, but it disenfranchises another subgroup from treatment? How do we handle that? And these philosophical arguments can be applied to any of these approaches. So on this slide, we're just looking at a number of fixed thresholds, fixed major osteoporotic fracture thresholds in the setting of the UK. In postmenopausal women over the age of 50. And the thresholds that we've chosen range from 5% 10-year probability through to a 30% or more 10-year MOF probability. And the impact on the proportion of the postmenopausal women that will be identified for treatment is shown on the left graph as a line graph, and then as a total proportion of the population above each of those thresholds on the bar graph on the right. So if we just look at the two extremes, so which illustrate the points here, if you pick a low threshold, such as 5%, then you're treating virtually the whole postmenopausal population. 86% would get treatment, and that would range from almost 60% of 50-year-olds to essentially 100% of anyone over the age of about 68 or 69. At the other extreme, if we take a threshold of 30%, then you can see that we would only be treating 7% of the population. And we wouldn't be treating anyone under the age of 60, by and large, and we'd probably only be treating about 1 in 4 of 80 and 90-year-olds. So the threshold that you set across the different ages has a big impact on accessibility to treatment, and that impact is age dependent because fixed thresholds tend to disenfranchise younger patients who are naturally at lower 10-year probabilities of fracture. So nonetheless, a large number of countries have looked at the analysis that's come out of the North America and said, okay, we'll adopt the major osteoporotic fracture threshold of 20%. This is just an analysis from a few years ago within Europe, looking at the proportion of the population. This is in men and women combined between the ages of 50 and 89 years, the proportion of the population that would lie above the 20% threshold. And you can see that ranges from almost 20% in places like Sweden and Denmark, right down to about 2%, 3% in places like Romania and Bulgaria, just reflecting the fact that there is lower risks in certain countries compared to other countries. The other way of looking at this is if on the right, and this goes outside Europe, because we've got examples from South America and from North America and Asia. We're looking here at a woman aged 65 with a prior fracture, BMI of 24, put into each of the models of the countries that are shown here. And to get a MOF probability of 20%, the T-score entered at the femoral neck would range from somewhere around almost minus 4.5 in somewhere like Venezuela, up to just below minus 2 in Sweden and Iceland. So the risk and the bone mineral density associated with the risk varies markedly across countries. So if we look, for example, at a major osteoporotic fracture probability of 20% in the Kingdom of Saudi Arabia, in a woman with prior fracture and a T-score, then you can see here we've got a 65-year-old woman, similar to the example shown in the previous slide, 65-year-old with a prior fracture, a BMI of about 24, and in Saudi Arabia to get a major osteoporotic fracture probability of minus 3.7. A major osteoporotic fracture probability of 20%, the femoral neck T-score would have to be minus 3.7. So a fairly low bone mineral density T-score. Likewise, if we have someone who has a better bone mineral density, and in this example, we're just giving someone who's right in the middle of the osteopenic category, still at the age of 65, but a T-score here of minus 1.7. So as I say, right in the middle of the osteopenic category. And to get to that major osteoporotic fracture probability of 20%, then that individual would have to have a number of risk factors to achieve this. She would have to have had a prior fracture, also have a parental history of hip fracture, be a current smoker, and be exposed to glucocorticoids. So the bar is a fairly high one. And even if we say, well, this is all around the 20% threshold, if we use hip fracture threshold of 3%, then this individual with this T-score would still need 3 out of these 4 risk variables to be present to achieve the hip fracture probability of 3% or more. So it's a high bar. It doesn't mean that countries shouldn't use fixed thresholds, and many other countries do use fixed thresholds, but that some thought should be given as to what that fixed threshold should be. And the question is, should that be country specific based on the epidemiology of fracture and mortality and so on in the country that's wanting to develop their own guidelines? So age-dependent thresholds, actually most of us, in terms of fracture risk, have been using age-dependent thresholds ever since we started using bone mineral density. So in this diagram, we're just looking again at postmenopausal women from the age of 50 up to 90, and the 10-year probability of major osteoporotic fracture on the left here. And you can see that in women at each of these ages with no risk factors, no BMD measured, and an average BMI in this particular population sample, you can see that in that population, the fracture probability rises with age at the upper end of this blue area into older age, and then starts to decrease because, as you know, FRAX, unlike many other risk calculators, takes into account the risk of death as well as the risk of fracture, and at older ages the probability decreases as the risk of death exceeds the risk of fracture. In many countries we have decided that if you've got a prior fracture, some countries say a prior vertebral or prior hip fracture, other countries say a prior osteoporotic fracture, that individual should be considered for treatment. And in the line here with the black triangles, we're looking at the probability in women at each of these ages who have had a prior fracture entered into FRAX. And you can see that this gives a threshold that rises with age and remains above, well above, the population who have no risk factors in the absence of a bone mineral density measurement. For those of us who have used bone mineral density as a threshold or as a gateway to treatment, then of course behind that bone mineral density t-score of -2.5 there is a fracture risk, and we know that that fracture risk is lower at lower ages, it increases with age, it decreases as we get towards older ages, the probability decreases as we get to older ages. But you can see at older ages, and in this example from the UK, around the late 70s, then actually having a t-score of -2.5 is somewhat protective. You have a lower fracture probability than the population without risk factors, because the age-dependent decrease in bone mineral density has occurred around that t-score of -2.5, which has remained fixed and is therefore better than the average bone mineral density in the remainder of the population. So, but we've been using age-dependent thresholds, risk thresholds, using a t-score of -2.5 for many years. So in the UK, whenever we launched FRAX back in 2008, we recognized that if the tool was going to be used, then we had to give guidance around that. And on the right, we took the approach that the intervention threshold, similar to the graph that I've just shown you, the intervention threshold should be if you have a prior fracture, then you should get treatment. If you have a probability at your particular age that is similar to or greater than a woman with a prior fracture at your age, then you should be considered for treatment as well. So this became a single age-dependent intervention threshold. The next decision we made was that, of course, bone mineral density is a risk factor, and bone mineral density could be added into every single individual patient's risk assessment. But in the setting of the UK healthcare system, where we don't have as good access to bone mineral density measurements as many other countries, then we decided to target the measurement of bone mineral density around this intervention threshold. And this gave rise to the amber area, so that in the absence of a bone mineral density measurement, the GPs and primary care health professionals would get access to a graph that had a traffic light system of green, saying that this patient didn't require treatment because the probability was low across the different ages. In the middle, because they were around the intervention threshold, and this would allow them to concentrate bone mineral density measurements on those who might move above the intervention threshold or from above to below the intervention threshold. So it makes maximum use of the bone mineral density measurements. And then finally this red area where they could consider treatment. And those age-dependent thresholds, of course, carrying a number like 20% or 3% around in your head is quite easy to do. but in age-dependent thresholds, it's a little bit more complex. But what we did right back in 2008 was that in the UK calculation model, we have this extra button that appears whenever the patient has had their fracture risk calculation done. Here we have a 62-year-old woman with a BMI quite low at 19.5 and a history of a parental hip fracture, giving her this risk profile at the age of 62. And if you click on View NOG Guidance in this individual, then that's taken through to the NOG website, the National Osteoporosis Guideline Group website, and plots that individual's major osteoporotic fracture risk on the traffic light graph that I showed you before. And at the value of 14, you can see that she's almost towards the upper end of the threshold. We might consider treatment, particularly if she's got no access to bone mineral density scans. But if we've got access to bone mineral density scans, then the guidance says measure BMD, not to look for a t-score of minus 2.5, but to take the BMD value, either as an absolute BMD or the t-score, enter that back into the FRAX calculation and treat the BMD as an additional risk factor that refines the fracture risk assessment in this individual. If we send her off for her bone mineral density, then you can see that at a femoral neck t-score of minus 2.5, this lady would now sit above the major osteoporotic fracture threshold and close to it at the bone mineral density at the hip. And she would be recommended for treatment. And in this particular guideline, when you click on the treatment button, it gives guidance about the particular treatments that might be considered for use in this individual. So providing access to the risk assessment and providing access to guidance around the use of the output from that risk assessment and the automation of it, so linking the FRAX tool, FRAX calculation page for whichever country to a website that provides guidance about what to do with that result, it seems to work very well. And this is these are old data from about almost 10 years ago now, where we were able to use Google Analytics to look at the usage of FRAX within the UK, and at the same time look at the use of NOG within the UK. And you can see that the two graphs are essentially identical. And about 1,000 calculations a day in the UK, largely in primary care, were coming through from the FRAX website to the NOG website to learn and get guidance about what might need to be done about that particular individual for their future management. So thresholds are important. Stratification of risk is important because it allows us to decide to treat or not to treat. But the question then is, which treatment? And in the past, we've largely said, this individual has osteoporosis, or this individual has a fracture risk above a threshold. Here's the list of drugs that are licensed for this for osteoporosis, and then the individual the individual clinician had largely make up their decision about what treatment to use. And of course, we could take into account various things such as prior fracture and prior exposure to medications and so on that would guide us. But more recently, there has been a movement to actually looking at the fracture risk stratification to help us to guide treatment decisions. And that has largely arisen from us having access to, for the first time really, head-to-head trial from studies that show that one agent is better than another available agent. And the two studies that really have changed this thought process were the studies, on the left here, this is a mistake. This is not romosozumab versus alendronate. This is teriparatide versus risedronate. So my apologies for the mistake there. It's from the paper from David Kendler and colleagues in The Lancet in 2018. And if you concentrate on this one, this is teriparatide in blue, risedronate in red. And you can see that in this high-risk population, teriparatide showed a greater, more rapid reduction in vertebral fractures than risedronate. And on the right, we have the ARCH study with romosozumab, and you can see that here we've got alendronate in grey, we've got romosozumab in orange, and again the reduction in vertebral fracture rates is greater with the romosozumab and alendronate, and also occurs rapidly within the first 12 months of treatment. So we've got evidence that some treatments are better than others, that are greater at reducing fracture risk and more rapid at reducing fracture risk. And this really goes back to a concept that this is actually a diagram that I put together for a meeting in Japan about 14 or 15 years ago, and just looking at the concept of stratification of risk and the influence that might have on the choice of treatment. And we didn't really have much trial evidence at the time to support this. But we're looking here at looking after postmenopausal women from the age of 50 to the age of 80. And the risk here, I haven't put numbers on the risk here, but just categories of low, high, and very high. And you can see that in the early 50s, around the time of the menopause, then menopausal therapy or hormone replacement therapy could be useful. The line here, the grey line that runs the whole way across the slide, is a sort of theoretical intervention threshold. And as you'll see, some of the women who get HRT will be above that line, but some of them will be below it because they need the HRT for other additional non-skeletal benefits. Similar true for selective estrogen receptor modulators. And then as we get into the older population who are tending towards high risk, then oral bisphosphonates, and if you've got access to other treatments such as strontium ranelate, can be considered in the setting of high risk. Once we start to transition from high risk towards very high risk, then at this time I had the schema device showing intravenous bisphosphonates or denosumab in this region, and then anabolic or bone-forming treatment towards very high risk. And that schema has largely been followed by recent guidance. This is from European guidance that was published 3 years ago now in Osteoporosis International. And we have this sort of low risk, high risk, and recently this new category of very high risk. And this risk stratification then allows us to stratify the treatment options as well, and those treatment options reflect the ones that I've just shown you on the previous schema that I devised a few years ago. Now, of course, there are a number of ways of deciding what very high fracture risk is, and in this paper from the AACE guidelines in 2020, the approach was taken to use largely categorical assessments of very high fracture risk. So they recognize factors such as a recent fracture, because we know the impact of that on future fracture risk. So recent fracture could mean very high risk. Fractures that occur while on approved osteoporosis therapy, of course, that might result from lots of things, and if it's oral bisphosphonates, frequently results perhaps from poor adherence to treatment medication. But they recognize that fractures which occur during treatment could indicate very high fracture risk. Multiple fractures is a fairly easy one that I think most of us would agree with. Fractures while on drugs causing skeletal harm. This is a little bit difficult because we've got less access and less licensing around the use of bone-forming treatments, such as the more recent treatments in the setting of long-term glucocorticoid use. Or it could be a very low T-score and so on. So I'm not going to go through these all one by one, but the last one does mention a FRAX thresholds. And here, instead of 20% very high fracture risk, has been an example has been given showing it as at 30%, and instead of hip fracture at 3%, very high fracture risk is set at 4.5%. But again, these are largely numbers that are sort of a little bit picked from the air as to what very high fracture risk things would mean. But I think for most of us, a risk of more than 30% in the next 10 years of major osteoporotic fracture is something that we would like to treat properly and effectively to reduce future fracture risk. The approach that's been taken in Europe is also to really adapt the approach that was taken initially by the National Osteoporosis Guideline Group in the UK and then by European guidance This is the line here in the middle of the amber area, is the original intervention threshold, which is the probability of fracture in a woman at each of these ages with a prior fracture. And the suggestion was that there would now be, instead of 3 categories, there would be 4 categories. Low risk would remain. Once you've had a BMD measurement and you fall below the intervention threshold, then you would be categorized as low risk after BMD. If you're above the intervention line, you'd be high risk after BMD. And then between high risk and very high risk would be a new intervention threshold. And this new intervention threshold would suggest that you could perhaps consider bone forming treatments rather than bone resorption treatments as first line. In the UK, we've applied a very, very similar approach. We've been a little bit more conservative, given just the nature of healthcare funding. So instead of having a threshold which would have arisen from the original NOG guidance between high and very high fracture risk, this would have been at a threshold which is 1.2 times this low intervention threshold probability. We just modeled some approaches to setting the thresholds, and in the final guidance we have opted to use a 1.6 times this low intervention threshold, because it identifies about 10% of women over the age of 50 as being at very high risk, with 30% being at high risk. So the majority would still receive the mainstays of our osteoporosis treatments that we've had around for the last 30 years or so, but a small proportion would be targeted for more aggressive intervention using treatments such as bone forming treatments, because they were determined to be a particularly very high risk. So this is just an output from the recent National Osteoporosis Guideline Group update that was published early in 2022. And you can see that it's not an automatic, you must give this patient anabolic or bone-forming treatments, but the suggestion is that the very high-risk patient should be referred to an osteoporosis specialist for consideration of parenteral treatments, and of course that includes subcutaneous denosumab, intravenous bisphosphonates, and or bone-forming agents such as teriparatide, abaloparatide, and romosozumab. Those indications for specialist referral could include, the bottom of the slide is the FRAX probabilities, or in those who don't use FRAX, then there were other categorical thresholds that could be used to indicate the need for specialist referral. So again, this is the most recent NOG thresholds, translated into these risk areas: a low risk green area for giving lifestyle advice, the amber area around the intervention threshold, which after the measurement of bone mineral density will be reclassified as a high risk or low risk. And then we've got this very high risk category, again, consider specialist referral and treat. One of the things that we recognized is that particularly at older ages, particularly in frail individuals, then the assessment of bone mineral density is often complex and often an arduous thing for particularly frail patients to have to go through. And so the recommendations are that in the absence of BMD, if it's just not practical, then just to use this lower intervention threshold. And you can see that the X here is just above that intervention threshold for this individual, and you can make the decision to go ahead and treat without the need for bone mineral density assessments. So that's the approaches to risk stratification that have been applied over the last 30 years or so in the management of osteoporosis. The ability to assess absolute fracture risk actually allows us to refine thresholds to a much greater extent than just the simple use of T-score thresholds and prior fracture thresholds. It allows us to input other risk variables into that calculation above bone mineral density and above prior fracture. And that's an approach that I think will prove useful in the future for allowing us to have better access to bone forming treatments as first line treatment. So to summarize, risk stratification is evolving. In the management velocity process, we're moving away from the simple decision of to treat or not to treat, but increasingly towards which treatment to choose. As I've tried to address in the talk, different FRAX and non-FRAX approaches can be used to describe very high risk. Thresholds for risk stratification by tools such as FRAX can be defined, and those can be individualized to different countries to make it more practical and applicable for use at individual country level. The point that I made early on, I guess, about the interaction between FRAX and NOG, is that if we can automate the implementation between the risk assessment and the action that might flow from that, then that provides ease of use in clinical practice. And again, thank you very much for your attention, and I look forward to answering your questions later.